I'd like to welcome you to this educational symposium, which is entitled At the Crossroads of Evidence-Based Non-Small Cell Lung Cancer Care, Navigating Current and Emerging Treatment Paradigms.
This audio is part of a certified educational activity titled At the Crossroads of Evidence-Based NSCLC Care, Navigating Current and Emerging Treatment Pathways. To access the entire activity and complete the post-test, please go online to www.peerviewpress.com/UDX40. A printable monograph, slides, practice aids, and other features are also available.
I'm Dr. Ross Camage from the University of Colorado Cancer Center in Aurora, Colorado. Joining me are Dr. Mark Sosinski from Florida Hospital Cancer Institute in Orlando, Dr. David Spiegel from the Sarah Cannon Research Institute in Nashville, Dr. Pasiani from Harvard Medical School in Boston, Massachusetts, and Dr. Alex Strelin from Memorial Sloan Kettering Cancer Center in New York. So we are going to focus on the whole range of treating advanced non-small cell lung cancer. And we're going to do it in two broad chapters. The first relates to everything that doesn't have a sensitizing gene mutation or gene rearrangement. And we really have a star panel tonight. We'll start off with Mark Sosinski talking about first-line therapy, and then David Spiegel talking about second-line therapy. Then we'll have a group discussion. That would be a great time for your questions to come in. Then we'll move to the second chapter, which is about those with sensitizing mutations or gene rearrangements. We'll have Pasiani talking about EGFR and ALK, and then Alex will talk about some of the new emerging targeted therapies for certain predictive subgroups. And again, a discussion at the end. So together with PeerView, we developed a series of infographics as cards or posters. These are my best guess at a summary of what our experts are going to talk about. So without further ado, let's bring on Dr. Sosinski to start part one of our discussion. Mark.
So I've been asked to kick off the decision-making process in advanced non-small cell lung cancer in those patients that don't have oncogenic drivers. The three actionable genotypes in the first-line setting really are probably across the country in routine practice limited to 10 to 15% of the patients. And so the real issue is how do we manage the vast majority of patients who don't have driver mutations or other gene rearrangements. Having lived through the 90s as a clinical investigator in lung cancer, it does disappoint me that I can sum up the decade in one slide. These are the lessons learned in the 1990s. When I started in this business, the only platinum available was cisplatin, which was terribly toxic at the time. We learned that carbo led to similar outcomes. The drugs of the 1990s, really the taxanes, gemcitabine, and vinorelbine, I should have added irinotecan to that, the so-called third-generation cytotoxic drugs, were slightly superior to second-generation etoposide and other. And the other issue is we had initial high hopes for non-platinum doublets, but that was not realized. We tested a number of drug strategies, 1 versus 2. Generally, 2 were better, particularly when you added to a platinum, but 3 drugs did not improve overall survival in this setting, but did increase toxicity. Duration of therapy, the biggest bang we get is in the first 3 to 4 cycles, and that longer durations did not necessarily improve survival outcomes, and that chemotherapy did not negatively impact quality of life. And we kind of ended the decade with ECOG 1594, and I don't have a slide of that now, but you can remember that was the famous Joan Schiller trial with 4 platinum-based doublets, all of which were identical. It led to a New England Journal publication. And we came out of the 90s thinking that it was a platinum-based doublet, but it really didn't matter which doublet you used. Well, so the question is, does the choice of platinum doublet matter? Well, I think the first example of that was the pemetrexed data in the Scagliotti trial comparing cisplatin gemcitabine to cisplatin pemetrexed. And embedded in that was a pre-planned analysis based on histology. There were some theoretical reasons based on TS levels that pemetrexed may be less efficacious in squamous and more efficacious in non-squamous. And you see here that in this pre-planned analysis, there was a modest benefit from pemetrexed relative to gemcitabine, where the opposite, in non-squamous, where the opposite was true in squamous. I think the lesson here is really that pemetrexed is not a very efficacious drug in the squamous population, and we should avoid it because we have better things. I don't take this to mean that gemcitabine is the best drug in the squamous population. Actually, in my practice, I prefer taxane-based therapy. So this is one example where choice of platinum does make a difference. A second example is the nab-paclitaxel data. This was a trial comparing nab-paclitaxel or albumin-bound paclitaxel with carboplatin versus standard solvent-based paclitaxel carboplatin. There was a difference in the schedule of taxane, with nab being weekly, where solvent-based was given every 3 weeks. At least in lung cancer, there was not evidence, or I don't think there is evidence today to suggest that taxane schedule makes a difference from an efficacy point of view in this setting. Because paclitaxel was an approved drug, the FDA allowed us to look at overall response rate as the primary endpoint, and you can see this did actually meet its primary endpoint. But surprisingly, that the overall response rate was driven principally by the squamous subset of patients. You see here in non-squamous, response rates of approximately 25%, not different, but in the squamous population, 41% for nab paclitaxel versus 24% for solvent-based. We did not anticipate this in this study. We did not have the opportunity to necessarily power the study to look at survival endpoints. At the end of the day, although there were trends toward better PFS and OS, they were very modest and not statistically significant. The biologic reason for this remains undefined, and it's really not been explored in a way that many of us had wished it was. So the next question is, does adding a targeted agent to chemotherapy matter? I think the key example of that is bevacizumab. Here are the 4 phase 3 trials which tested adding bevacizumab to various chemotherapy platforms. This table is bookend by ECOG 4599 to the left and the Beyond trial to the right, both of which had overall survival as the primary endpoint. The Avail trial and then a Japanese trial are shown in the middle columns. These 4 phase 3 trials met their primary endpoint. I don't think we can ignore 4 positive phase 3 trials, and I think for the appropriate patient, bevacizumab grafted onto the chemotherapy doublet is an important strategy for this population of patients. There's been a bit of decay in the enthusiasm for bevacizumab. Here are the Beyond overall PFS to the left, as well as survival curve to the right, really fairly identical to the ECOG 4599 trial. So we have 2 examples of overall survival. So there are lots of reasons not to give bevacizumab. Not every patient is an appropriate candidate for bevacizumab, but those patients that are eligible and do not have contraindications, I think bevacizumab adds to the options of better treatment for patients in this setting. Well, what about EGFR monoclonal antibodies? The 2 first trials, FLEX and the SWOG 0819, tested cetuximab. Even though FLEX was technically a positive trial, it did not lead to an FDA indication. The SQUIRE trial tested the fully humanized cetuximab nesitubimab in combination with cisplatin and gemcitabine in the squamous population, and actually led to an overall survival benefit. You see here the SQUIRE primary outcome was overall survival. And again, we see a modest benefit in overall survival. There was no difference in overall response. A significant, although not necessarily clinically impressive, difference in disease control rate in a similar hazard ratio for PFS as we had for overall survival. There was some one of the issues with EGFR antibodies is the issue of a biomarker. There was some suggestive information from the FLEX trial that using immunohistochemistry for EGFR was helpful. We did explore that in the SQUIRE trial, and there was really not an H-score that suggested that you could identify patients for a greater or lesser benefit in this setting. There were no surprises with regard to the toxicity, other than the rate of hypersensitivity, which was relatively low since it was a fully humanized antibody. This is FDA approved. It's really had a funny path, initially listed in NCCN guidelines, but then removed from NCCN guidelines, making a judgment on the modest survival advantage in this particular setting. I'm not a member of the NCCN, so I did not participate in those discussions, but you won't see this FDA-approved drug in the NCCN guidelines. It still remains an option, in my opinion, for selected patients with squamous histology. Well, I think all of us would agree we've hit a ceiling with platinum-based doublets. Is there something better than chemotherapy in the first-line setting? And that leads to the immunotsunami that we've experienced over the past 2 years in lung cancer. And I think we all understand that tumor immunology allows the cancer to develop mechanisms to shield itself from the immune system. The pathway that we've manipulated has been the PD-1, PD-L1 pathway, as shown here. By inhibiting this, the theory is that you can reactivate the immune response at the level of the cancer and show benefit. We also had some real hints that you could identify patients by measuring PD-L1, by immunohistochemistry, that got greater benefit. And I'll just draw your attention to the lower row, the overall survival hazard ratios, and looking at the hazard ratios when the total proportion score was 50% or higher. This was taken from the second-line trial, KEYNOTE-010, and you see the hazard ratio for OS was in the 0.5 range. So if there was a targetable population, the high expressors seemed to be the targeted population, and that was the intent of KEYNOTE-024. It selected previously untreated patients that had a total proportion score for PD-L1 greater than or equal to 50%, good performance status patients. I will point out that it excluded patients with EGFR mutations and patients with ALK translocations. The randomization was to pembrolizumab at a flat dose every 3 weeks versus platinum doublet therapy. The primary endpoint was progression-free survival, and the secondary endpoints as shown here. This is the PFS. There was an impressive hazard ratio for PFS of 0.5 with a significant p-value. You see at 6 months a difference of about 12%, but quite a significant difference of roughly 30% in prevention of progression at the 1-year time point. So very impressive primary endpoint here. The overall survival also was significantly in favor. And remember, from the KEYNOTE-010, the hazard ratio for survival versus chemotherapy for pembrolizumab was in the 0.5 range. Here we see a hazard ratio of 0.6. The median overall survival in this analysis has yet to be reached, and obviously a significant p-value, and you see here the same figures at 1 year. We all rejoiced, I think, in 2005 when Alan Sandler had a 1-year survival rate that was above 50%. Here we have a 1-year survival rate, admittedly in a selected population of 70%. And I would argue that the control arm with a 1-year survival of 54% performed relatively well in this setting. The DMC for this trial recommended stopping of this. One of the issues here is that we don't yet have full follow-up on the percentage of patients that might have crossed over to other therapies, and certainly there'll be more data forthcoming from this particular trial. I will point out the response rate to single agent, 45% for pembrolizumab, a fairly standard platinum-based doublet response of 28%. What we've seen with immunotherapy is the durability of response with immunotherapy is much greater than we see with chemotherapy. So an important observation in this setting. Toxicity, you see here that the blue bars, which represent chemotherapy, significantly outweigh the purple bars. We also note that most of the toxicity focusing on pembrolizumab is grade 1 or 2, very little grade 3 toxicity. If you look at immune-related adverse events with pembro, we see thyroid rises to the top. But it's important to remember this is a different spectrum of toxicity. As Julie Bramer says, anything that ends in itis can occur in this population. You need to be vigilant and recognize it early, but certainly in this experience, this is not prohibitive toxicity. And to summarize this, again, we had a superior survival experience as well as PFS and a toxicity advantage in this setting. So in that population of greater than 50%, this is now the standard of care. Again, it's important to remember that this is in high expressors and in patients who do not harbor EGFR or ALK aberrations, as shown on the bottom part of the slide. And this was added to the NCCN guidelines as shown below. Well, is there something better than immunotherapy alone in the first-line setting? And that brings up the recent approval of the combination of pembrolizumab with carboplatin and pemetrexed, the so-called KEYNOTE-021 cohort G. This took, again, non-squamous, advanced, untreated patients. Again, excluded EGFR mutants and ALK translocated patients, good performance status patients, randomized to carbo-pem with or without pembrolizumab, as shown here. You could cross over on the control arm to pembrolizumab at the time of disease progression. The primary endpoint was overall response rate. And you see here the response rate for chemotherapy, again, pretty standard for a doublet at 29%. Adding pembrolizumab increased that response rate to 55%. This was not only clinically impressive, but statistically significant. And again, getting back to the durability of the response and the median, it's still not reached in this experience. The other important point is the median time to response was actually a little better on the pembrolizumab arm, but widely overlapping confidence intervals. Interestingly, these are very small numbers, but you see here in the population that we just talked about, I think this creates data. If you have a patient with a greater than 50% proportion score today, what are you going to do? Are you going to use pembro alone, or are you going to combine it with chemo? I showed you pembro alone had a response rate of 45%. Here we have a response rate, I know it's a limited number of patients, only 20 patients, but a response rate of 80%. Remember the durability of the responses. Since when you have long, durable responses, they may very well drive survival endpoints, which we don't typically see with cytotoxic therapy. Again, here's the PFS. Both of these arms did quite good. Even the control arm, 8.9 months with carboplatin pemetrexed is pretty impressive. Here we had 13 months on the combination arm. No difference in overall survival as shown here. This was very early follow-up. I think the median follow-up at the time of this reporting at ESMO was 13 months. No difference. Toxicity, again, you see that adding pembrolizumab does increase things, fatigue, nausea, a minor increase in other GI toxicities. Again, since most of this is grade 1 or 2, very little grade 3, I don't think that there's any prohibitive toxicity signals in this experience. And again, adverse events of possible immune etiology are shown here, largely relating to the thyroid, but others scattered in there that you need to be aware of. Again, fortunately, the majority grade 1 or 2. So I read in the ASCO post that on May 11th, 2017, that the FDA approves pembrolizumab on the accelerated approval process for first-line combination with this doublet. And actually in the indication, it really is without regard to PD-L1 status.
At ASCO 2017, updated data from Cohort G of the KEYNOTE-021 trial were reported. The first-line combination of pembrolizumab with pemetrexed and carboplatin chemotherapy reduced the risk of progression or death by 50% compared with chemotherapy alone, and nearly doubled the objective response rate for patients with advanced non-squamous NSCLC.
So is this triplet regimen now the standard of care or simply an option? Personally, I'm not ready to embrace it as a standard of care. I think we have to remember this is phase 2 data. There are toxicity issues, but not prohibitive. The response rate is about 50%, and it leaves the question open is could sequential therapy prove to be as good? What do we have to look for next? Well, we have a number of phase 3 trials that will explore this issue of adding immunotherapy to platinum doublets, other immunocombinations, and some trials addressing the different strategies in PD-L1 negative versus positive patients. Here's a list of the first-line Atezo trials in combination with chemotherapy or against chemotherapy. Checkmate 227 is exploring both addition to chemotherapy as well as novel immuno-oncology combinations, the nivolumab-ipilimumab combination. And then probably the first trial we'll see in the not-too-distant future is the MYSTIC trial, which again explores monotherapy with durvalumab and anti-PD-L1 versus the combination of that agent with tremelimumab versus standard of care chemotherapy. So in conclusion, advanced non-small cell is becoming an increasingly complex disease. One of our demands is to get adequate tissue, and this really requires a multidisciplinary approach. Platinum-based doublets remain an option for many patients, but immunotherapy is now among the standard options for the first-line patients that have high expression and no targetable genomic alterations, and certainly I think for selected patients in combination with carboplatin pemetrexed. Thank you.
The role of immunotherapy beyond the first-line setting is getting increasingly confusing, and the available patients for single-agent checkpoint inhibitors, the drugs that just were approved in the last couple of years, is shrinking. So if you think about the patients that are available for single-agent checkpoint inhibitors, it's not going to be anybody who has non-small cell or non-squamous non-small cell lung cancer. So all of our adenos in large cell either will have high PD-L1 expression or they'll have low or unknown, and they'll receive a Pembro regimen. So you're really talking about your squamous patients, and about a quarter of those are going to have high PD-L1 expression, probably a little bit lower, leaving you probably 10 to 15% of all of our patients that we're seeing available for single-agent checkpoint therapy in the second or third line. It's amazing to think how much has changed just in the span of a couple of years. But more work needs to be done, obviously, to figure out how to help these patients. So what's out there today, what's been out there since nivolumab and Pembro first got approved? Just to review this briefly, how we got here. Nivolumab obviously has an approval in the, we often say second-line setting. It's the refractory setting. The pivotal trials were all in the second-line setting, but the approval was in anything after first-line setting. Important to remember. That's both histologies, regardless of PD-L1 expression. Pembrolizumab, in addition to the first-line approvals Mark just reviewed, has an approval in the refractory setting as well. Both histologies, but with the caveat that this is in the so-called PD-L1 positive patients, but a different cutoff than in the first-line setting, an expression of 1% or higher, and I'll walk you through that from the Keynote-10 study. And then most recently, atezolizumab. This agent was the most recent drug approved in the refractory setting in both histologies, regardless of PD-L1 expression. So just to walk you through this somewhat quickly, because you all are very familiar with these data, these are the pivotal checkmate second-line or refractory trials with nivolumab, the 017, 057 studies. Remember, the 017 was in squamous on the left, 057 non-squamous on the right. Both trials and all the trials I'll talk to you about had a similar design. Patients in the second-line setting who are randomized to docetaxel or a checkpoint inhibitor, in this case nivolumab. The primary endpoint of each of these trials was overall survival. We have 2-year follow-up now, and you can see that the survival remains still compelling and justifying their use in this setting. Patients were assessed for expression. It was not a requirement to get on the study. Patients had to have tissue, however, for that assessment. And if you look at various cutoffs here on the left, 1% cutoffs, 5%, and then 10% on the far right, and then split by whether patients were above or below that cutoff for docetaxel in the lower 2 lines, and then for nivolumab in the upper 2 lines, you can see that survival advantage is maintained throughout that expression cutoff for squamous patients. A different way of looking at this for the 057 non-squamous patient population, if you look at the percent of patients who are alive at 2 years by PD-L1 expression, Everyone, the intent to treat group is on the far left there. You can see the hazard ratio 0.75 in favor of nivolumab. And as you walk that across, certainly for the 1%, 5%, and 10% or higher, the advantage is in favor of nivolumab over docetaxel. It's important to note that in the less than 1% cutoff, the hazard ratio crosses 1, so not as clear of an advantage there. We now have 5-year follow-up from the really pivotal phase 1 study that helped to define this story. So these are patients who were very refractory, treated with nivolumab following several lines of prior therapy, and we see in this interesting group of patients in the pivotal group that led to the randomized trials that there's about 15 to 20% of these patients still alive at 5 years, which is really quite remarkable. Pembrolizumab's pivotal trial was Keynote-10. Roy Herbst published this in Lancet. And what is important to show here is that if you look at overall survival by different cutoffs, either 1% expression of PD-L1 on the left or 50% expression, the advantage is in favor of pembrolizumab over docetaxel. A bit of a confusing story of how this happened. If you remember, Pembro got on the market with a 50% approval based on phase 1 data published by Eddie Guerin in the New England Journal. But then this pivotal phase 3 study expanded that expression level to 1%. But this is different from the first-line setting where it's still 50% or higher. And then most recently, atezolizumab, we had seen data a couple of years ago from the randomized phase 2 study, the Poplar trial, but this was the registration phase 3 study, the OAK study. Again, similar design of comparison versus docetaxel. A little bit different in that the PD-L1 expression used in this trial was looked at in different ways in the other studies. So looking at expression of PD-L1 in the tumor cells and the infiltrating immune cells. But any way you looked at that in the intent to treat population, whether you had 0 or 3+ expression by tumor cell or immune cell expression, I'll show you that in a moment, the advantage was in favor of atezolizumab. And that's shown here this way. There is a hint of benefit as the stair-step approach with higher expression, but the bottom line is all patients seem to benefit, even the zeros, and that's why the FDA approved atezolizumab to be used in all patients, regardless of PD-L1 expression. This is an interesting paper on the patients who received atezolizumab beyond progression. Actually, every trial I just showed you was built to allow patients to remain on study if they were doing well from a toxicity standpoint and otherwise tolerating therapy, and even if they had new disease, the investigator was allowed to keep their patient on studies. And then just to point out that these aren't the only 3 drugs in development. Some other drugs are close behind. I don't think too far behind. These are going to be important therapies. So there's Avelumab. These are the Javelin trials. This trial is fully enrolled. We're waiting on the results. A similar design of Avelumab versus docetaxel. This is a PD-L1 inhibitor. Durvalumab, which you heard about recently, press release showing benefit in stage 3 patients. Not yet FDA approved in lung cancer, but we certainly expect that to happen soon. But there's this Arctic study looking at the role of durvalumab as a single agent in patients in the 3rd-line setting. Kind of an interesting setting to end up in, but still a nice way to have a drug on the market to be available for our patients. And then other analyses looking at this in patients with EGFR mutations and T790 mutations specifically. So what do we do now? Do you offer patients just nivolumab or atezolizumab or pembrolizumab? What do you do for patients who are receiving pembro in the first-line setting or carbo-pembro? What are their options? Well, we don't know the value of receiving any of these agents following pembrolizumab. So, and even a PD-L1 inhibitor following a PD-1 inhibitor, at least in theory, you'd think that there shouldn't be any additional benefit. But the truth is we don't have any data. I know there's a study in Europe, and our own center is launching a study to look at this question to understand whether there's merit in that strategy. But really, a lot of the work that's happening now is looking at novel combinations, taking patients who have either benefited from their immunotherapeutic they've received and have progressed, and then continuing that and adding a new drug into that, or replacing that with a novel immunotherapy combination. I just mentioned these 2 programs, so Fraction and Morpheus. These are strategies to look at the role of new combinations in patients who've been exposed to prior immunotherapies. These are large programs that have multiple cassettes or different protocols within them that allow patients to experience, for example, progression on nivolumab, then to receive nivolumab plus a new agent, say a LAG-3 inhibitor or Dacomitinib or another combination that's coming out of their pipeline. The same is true for Morpheus with atezolizumab. I think these are very important studies, but we're still early in this, and so we don't have answers. We've seen recently some press about the partnership of some companies with combinations, so drugs that they're developing but they don't each own. So this is the IDO inhibitor. IDO is an enzyme that's involved in T-cell suppression, and inhibiting this enzyme and the catabolism of tryptophan specifically may release T-cells and allow them to fight the cancer or attack the tumor specifically. So combining an IDO inhibitor with a checkpoint inhibitor may be a strategy worth pursuing. We have some data from Keynote-037. It's a complicated schema here, but this IDO inhibitor, epacadostat, has been combined with pembrolizumab, and we've seen some preliminary data where there is evidence of responses and activity with this combination. Shown in light blue here is 4 or 5 PRs are ongoing, just shown here in these spider plots. Let me just mention that there's an ambitious program of IDO combinations about to launch in phase 3 settings. So these early data, and you'll see some of it in these presentations here at ASCO, have led to the development of combinations for registration with pembrolizumab, and then others are happening with nivolumab. Just one example of the many combinations being developed, but we still don't have answers for. And then just to finish up here, to show you that we still have everything else, things like single-agent docetaxel and gemcitabine and vinorelbine, but they remain options for our patients beyond immunotherapy. And of course, we also need to remember docetaxel and ramucirumab, a combination that beats docetaxel in a randomized phase 3 study, remains an option for some patients. I think hopefully, though, we can do better than this and find newer options for our patients. So in conclusion, we have 3 FDA-approved agents right now, nivolumab, pembrolizumab, and atezolizumab, to be used in all patients in the second and beyond setting, regardless of histology. Only pembrolizumab requires PD-L1 expression at the 1% cutoff level in that setting. However, the movement of pembrolizumab into the first-line setting, either as a single agent or in combination with carboplatin and pemetrexed, I think is obviously going to reduce the patient population that will receive or be candidates for single-agent checkpoint inhibitors. And we don't know the value of those drugs after pembrolizumab, and I would hopefully plead that we need to have those patients be studied and not just empirically give those therapies without data. Studies are launching in that realm. And then multiple immunotherapy-based combinations as salvage regimens remain promising. I didn't mention other combinations with angiogenesis inhibitors, and then also novel strategies like vaccine and even CAR-T programs have launched. In fact, at our center and at Moffitt and some other centers around the country, CAR-T, which has been a program of therapy available for in the pediatric setting and the hematologic setting, is now advancing into the solid tumor setting, and they're moving into lung cancer right now. So with that, I think I will end.
We now have about 10 minutes for questions. I'm just going to remind you, in case you need any prompts, that some of what we've talked about is really on the right-hand side of that first infographic here. Mark, you gave a wonderful discussion about all these other agents. You know, they're licensed, bevacizumab, necitumumab, but you know, how are you going to use them in the setting now of the immunotherapy world?
That's a great question, Ross. You know, our universe is in the process of being redefined, and so we're rethinking these sorts of things. I think that in my practice, the only clear role for IO to me is in the high expressors, and that's what I do. I obviously, the approval of the 21G data is only a couple weeks old. I'm still haven't seen a patient where I thought that was the best option for that particular patient. So I think these remain relevant options for patients. I will admit they don't get exercised very often because of the expanding options that we have in this space. And certainly the 21G data puts a certain spin on it that I think that probably the use of these two agents is going to be less and less than it is now.
There is an ongoing randomized study including Bevacizumab with an IO and chemo?
Yes, the Empower 150 trial is looking at the control arm of Carbotax Bev versus Carbotax Bev plus Atezo versus Carbotax Atezo. So a 3-arm trial, either adding to Bev or replacing Bev is the strategy. That trial has completed its accrual, I believe, and so we'll see.
Yeah, there's a huge suite of Atezo studies, but that's the first one to read out hopefully this fall.
Yeah.
So give me your best guess. Do you think Bevacizumab is going to make a difference in this setting?
There is some information that the angiogenesis and immunotherapy worlds can come together and at least be additive in the effect. So I'm hopeful that it will actually, but we don't commonly use very many 4-drug regimens in this disease, and so it really begs the question. One thing we haven't addressed is knowing that these are active as second-line therapy. Is there an advantage to sequencing these sorts of things? And so that is a question that I think has to be addressed also.
Are there patients now who you would say you shouldn't give immunotherapy to in the first-line setting?
The obvious answer is someone who has some autoimmune disease that it would be a contraindication. Those patients were excluded. I would not give it to an EGFR mutant patient or an ALK translocator or other oncogenic driver patient. Those are the ones that immediately come to mind.
This is a great question. This actually, Patty and Alex, this rings a certain bell because it sounds almost like how we used to think about EGFR and mutation testing. The question is, do you wait for the PD-1 test to come back to determine your treatment in the first line, or do you start chemo, and then if it comes back and it's high, what do you do when they're just on the chemo?
Well, I think it depends a little bit on what your pathology laboratories are doing, and I think different places are adapting to this differently. Our pathologists have sort of routinely reflexed to doing PD-L1 testing, so when they do the TTF1 and others, the PD-L1 is there as well, so it is available at that time. I don't think we know yet what to do in somebody where you get that test later and they're responding to chemotherapy. What do you switch? Do you add? We don't have endless therapies in lung cancer either. Usually I like to stay with ones that are working and then use the other ones that later on down the line.
I mean, the one advantage that PD-L1 has is an IHC test, so it's a 2-3 day turnaround time.
Quick.
So it's not like molecular testing where it can take
Although,
long.
I agree with you that should be that way, but a lot of community settings, it's still taking over a week or 2 weeks to get back.
Especially if it's a send-out test sometimes.
Right.
Yeah, for sure.
So Alex, what would you do?
No, in my mind also, it depends really on how sick a patient is.
Okay.
And if someone can wait to complete the cadre of testing, then I would rather have all of the information at my fingertips. The only situation where I might be tempted to just go ahead with chemotherapy without knowing PD-L1 status is perhaps in somebody that's a never smoker who I might suspect might have a driver that's in his or her lung cancer.
So you made reference to treatment beyond progression, the David Gandara presentation that's going on. This is because of potentially the concept of pseudo-progression. How do you decide who you treat beyond progression with immunotherapy? Dave?
Yeah, well, it's tough. I think a lot of clinicians in here struggle with this. It's been a little bit different than the way we've always treated patients in any tumor setting where you see a new lesion or a growth in an existing lesion. You say, well, come off that therapy, let's move on to something else. And what we've seen here, and I explained to you in the trials, is you could have patients who are doing very well clinically, and yet there's growth in some lymph nodes or new lesions in the liver. And there's a suggestion that these patients will continue to do well if you keep them on their therapy. We tend to call some of these patients pseudoprogression, and some of it is tumor swelling, whatever term you want to use. The question is how much of it is real progression and how much of it is just an imaging artifact. I don't think we know for real. There's been some estimates that this is probably well below 5% of the patients we actually care for. But I was talking with some of my colleagues here earlier. I'm troubled by this thinking when you look at some data from Hopkins in patients with earlier stages of disease, but that included stage 3. These are patients that were going to surgery, and they gave them just 2 doses of nivolumab, and then they took them to surgery. And what they found is in about half of those patients, there was major tumor death, where there was very little viable tumor left. In those same patients, if you image them before they go to surgery, you only see responses in about half of that number, which tells me that what's actually happening at the level of the tumor is not accurately reflected in what's going on the scan. And so if that's happening with stage 3 cancer, could that be happening with more of our patients with stage 4 cancer? And I don't think we know the answers to that. And I think some of these patients that have new lesions or growth, you might be seeing that. And we all have stories. I'll tell you one real quickly of a patient with growth on a scan, hot on a PET, pain, had to come off the immunotherapeutic because of, we're on a study and that was true progression. We took that patient to surgery, removed that whole mass. There was no cancer in it at all. And it lit up on PET scan, caused pain, was growth on CT scan. You know, if that can fool you, could that happen at other levels in patients? So we just don't really know how frequent that is or how common. And it makes decisions tough about when to stop therapy, I think.
I've got 2 really good questions here. Somebody with asymptomatic brain metastases who's PD-L1 positive, do you treat the brain and then put them on immunotherapy? You try the immunotherapy first? What do you do?
We don't have a lot of data. I mean, there is some data with from Sarah Goldberg at Yale doing exactly that and showing a defined response rate. The actual number is escaping me. If someone else on the panel remembers, I think it's about 35% or so.
Right.
Yeah. But I think we've all become comfortable if we know therapy is effective, if we know the brain mets are small, asymptomatic, and not threatening, of giving systemic therapy and checking early to make sure that the brain is not progressing. So,
and define early. What's early for
6
you?
weeks.
6 weeks.
Yeah.
The question for the group is, what do we know about maintenance immunotherapy? Can you just give standard platinum doublet chemotherapy and then move to what's really early second-line therapies? What's interesting is the Pacific study, the stage 3 cancer. This included patients with unresectable stage 3, so locally advanced disease. We know most of those patients behave like stage 4 patients. Remember, all of them got chemo-RT and then were randomized to durvalumab or placebo. And what we know is that study was positive. We haven't seen the final results, but a press release came out recently. That doesn't answer the maintenance question, but it's probably as close as we're going to get to locally advanced disease receiving immunotherapy following definitive treatment.
Okay, and then the second question was, is there any evidence of a dose-response effect with immunotherapy?
Yeah, well, so far in all the phase 1 studies, often it's the 1/3 in 10 milligram dosing. There does not appear to be an obvious dose response. There was no MTD that was experienced with these drugs.
Do you have any comment on dosing by weight versus flat dosing?
Right, so we've moved to flat dosing for pretty much every drug now, and so the data have not been published, but they look to be equivalent, at least for nivolumab. So, I don't think it's likely that that's going to be a big deal there, but that's the drugs were not approved with flat dosing, at least for nivolumab and Pembro, but then that's where they're used now.
There'll be 2 presentations in this session. I'll present on EGFR and ALK, and then Alex will present on all other rearrangements and alterations. So really, we think of lung cancer at the genetic level very differently today than we thought about it just over a decade ago, and we really have, as we've already introduced, several different oncogenic subsets where we have targeted therapies for patients available. And really, one of the remarkable thing about this is that patients who have a targetable alteration, who get a targeted therapy with advanced lung cancer, typically live for multiple years. And this is data from the LCMC analysis that was published a few years ago. As of today, at least EGFR, ALK, and ROS are alterations where we have approved agents in the first-line setting and where a targeted therapy is generally used, and at least in EGFR and ALK, by randomized trials, shown to be better than chemotherapy. And as already alluded to, these are also patients that in general don't benefit from immunotherapy, and this is true for the EGFR and ALK patients, probably hasn't been extensively studied in some of the others. Now, EGFR inhibitors, this too is a changing landscape and will likely change throughout the year. We at the current time have 3 approved EGFR inhibitors all over the world: Gefitinib, Erlotinib, and Afatinib, all agents that have been undergone randomized phase 3 clinical trials compared to chemotherapy, and in all cases, the data favor an EGFR inhibitor, response rates ranging from sort of 60 to 80%, with PFS ranges hovering in the sort of 10 to 11-month ballpark. Now we're starting to get the next phase of data where there's comparative data on specific EGFR TKIs. The first one that has been presented and published is the so-called Lux-Lung-7 trial comparing Gefitinib to Afatinib, where the primary endpoint here was PFS. And here is the PFS curves for this, although it had a positive hazard ratio and a statistically significant difference. The medians were quite similar here. You can see the differences at 18 and 24 months favoring the use of Afatinib. And I don't think that this trial necessarily converted too many people who were users of Gefitinib to Afatinib, or those who used Afatinib away from using Afatinib to Gefitinib. They're, in my mind, a relatively equivalent trial. This is the so-called Archer 1050 trial of a drug called Dacomitinib, somewhat similar to Afatinib, had previously been tested in more advanced settings in patients that had failed prior EGFR inhibitors, was no different than placebo, same finding as for Afatinib. This is a much larger randomized phase 3 trial of 440 patients.
Based on data reported at ASCO 2017, Dacomitinib reduced the risk of disease progression by over 40% and showed an average of 6.5-month improvement in response duration as compared with Gefitinib in the first-line setting.
Now, of course, our major issue today isn't necessarily who to choose an EGFR inhibitor for. That's very obvious. But the issues that come when resistance develops. And here, a typical example of somebody who responded to erlotinib, developed resistance after a relatively long period of time of 20 months, and then harbors the very common resistance mechanism, the EGFR T790M mutation. And if you look in the EGFR space of the resistance mechanisms, really it's dominated by the T790M mutation, makes up about 60% of resistance mechanisms, with other ones, of course, there including MET amplification, small cell transformation, HER2 amplification. And you can also see that sometimes you can have multiple resistance mechanisms in the same patient or in the same tumor simultaneously. Now, Osimertinib, which is now approved as an agent to treat patients with T790M resistance, the data is based on the series of clinical trials, first the phase 1 trial, then phase 2 trials, and a more recently published phase 3 clinical trial, showing response rates of about 60 to 70%. On the left-hand side, the phase 1 clinical trial, and on the right-hand side here, the pooled phase 2 analysis. Here you can see the PFS ranges between 9.7 to 11 months. So again, a very similar type of response and a PFS in this subset of resistant patients as you get with your first-line EGFR TKI in all patients. And importantly, because T790M testing and knowledge of T790M needs to often happen relatively quickly as patients are progressing, there's a large degree of interest, of course, to being able to test this from plasma, from cfDNA. And this is analysis from the phase 1 trial of Osimertinib, where plasma was collected in all patients, positive or negative patients, and you can see that the response rate in patients who are tumor positive is exactly the same as the response rate in patients that are plasma positive. Now, it turns out that these are not 100% overlapping patients, and this is due to tumor heterogeneity. Sometimes you can have a tumor biopsy that's negative, but the plasma is positive. Patient will respond very well, and the converse is also true. Plasma can be negative, tumor can be positive, and the patient can respond very well. And this is now an approved test as well. Now, more recently, Osimertinib was compared to chemotherapy, and you can see here as second-line therapy, a significant improvement in PFS with a hazard ratio of 0.3, and a PFS of 4.4 months from chemotherapy, and 10 months from Osimertinib, very similar to what was seen in the phase 1 and phase 2 clinical trials. Now, one other advantage of this class of agents, which we again previously didn't have for EGFR inhibitors, is that they have a high degree of activity in the CNS. the CNS wasn't a formal analysis or a formal requirement in the early studies. It was sort of recognized during the course of the clinical development that the drug had CNS activity. And so these are patients from the trial who had baseline measurable CNS lesions and were followed serially. And you can see the response rate here is about 50% in the CNS. And for patients with oncogenic alterations who we anticipate, as I started out by saying, live for years, having options other than radiotherapy to control their brain metastases is incredibly important, because seeing long-term complications of dementia, et cetera, from radiotherapy are not pleasant. Now, the other area where osimertinib actually has clinical activities in leptomeningeal disease. So an even more devastating complication of lung cancer is carcinomatous meningitis, and there we've had absolutely nothing in terms of therapies. And this is from a trial called the Bloom trial, where patients were treated with documented leptomeningeal disease and were treated with a higher dose of osimertinib, the 160 milligram dose. And you can see the number of patients here who had a significant benefit and were on therapy for a long period of time. And it is really a clinical benefit, because untreated, this is a fairly devastating complication. So there'll be an updated presentation of the Bloom data at ASCO as well. Now, osimertinib has also been tested in the first-line setting, so if you have an effective agent in the second-line setting, the question is, can you do better in the first-line setting? This is a cohort from the phase 1 clinical trial where 60 patients were treated in the first-line setting. Here at 2 different doses, the approved dose and then a higher dose, because when this cohort was started, the dose hadn't been completely finalized yet. A 60-patient cohort that has a response rate of 77% here, and a PFS of approaching 20 months, so 19.3 months here, very similar for the two different dosing cohorts. And this has led to a now completed randomized phase 3 clinical trial called the FLORA trial, where patients were randomized in the first-line setting to osimertinib, or either to Gefitinib or erlotinib, depending on the part of the world that the patient was being treated. The trial has completed enrollment, and there's an anticipation that this will read out at the end of the year. And again, this could influence or change our first-line approaches or treatment for EGFR mutant patients. Now, there are other EGFR inhibitors in this class that have undergone development. These 3 here essentially have ceased development. There's a few others out there, and they have similar, or in some cases, lower rates of responses, different types of toxicities. None of the other ones are approved yet compared to osimertinib, and it's likely that, or it may be possible that one of the other ones will be, and more to come on that regard. So in terms of progression and how to think about this, as I mentioned, plasma is often a rapid way to test if someone is progressing on an EGFR inhibitor, and you can get a result back usually quite quickly. However, if it's positive, again, the data suggests that benefit from osimertinib is just as good as if it's tumor positive. However, if it's negative, there are still patients that are tumor positive. For whatever reason, their tumors don't shed into the plasma, but they too can still benefit, and those are patients that one should undertake a biopsy if the plasma is negative. It's important to continue to understand some of these other mechanisms of resistance. If you don't have a T790M mutation, do you have MET amplification? Small cell transformation is also something that has been seen with EGFR inhibitors, and something that we treat with small cell directed chemotherapy. And typically, if you progress on an EGFR inhibitor and there's no clear target, no T790M, nothing else you can treat with, the standard of care would be chemotherapy. Now, the story in the ALK space is both similar and different. First of all, we have a number of drugs that are approved in the first-line setting. We have crizotinib that's approved, Osimertinib, which was just approved a few days ago. In the post-crizotinib population, we have Osimertinib, Alectinib, and Brigatinib approved, so 4 drugs together. And then in development, at least 2 and more drugs, lorlatinib and ensartinib. So even though ALK is a much smaller population of patients than EGFR, we actually have many more drugs approved in that patient population. In the first-line setting, we have crizotinib, based on this study from Ben Solomon, comparing crizotinib to chemotherapy, showing, again, a statistically significant improvement in progression-free survival compared to chemotherapy. When patients develop resistance to ALK inhibitors like crizotinib, the resistance is also a little bit more complicated than on the EGFR front. only about a quarter of the patients is resistance mediated by a mutational mechanism, and the number of resistance mutations is also significantly greater than in the EGFR space. There are other mechanisms of resistance or other resistance pathways outside of a mutational mechanism that take place. As we get more ALK inhibitors, there's now increasing efforts to study is the mutational mechanism resistance more or less prevalent after treatment with different drugs and the types of mutations. So this too is an evolving landscape. You can see the different drugs here, alectinib, ceritinib, crizotinib, and you can see the spectrum of resistance mutations is quite different. It's possible that alectinib resistance, for example, will be more of a mutational mechanism resistance because it's such a potent ALK inhibitor compared to, for example, crizotinib. Another way to look at this in preclinical studies is to look at all of these different mutations and look at which drugs could potentially be effective here. So in red are drugs that are potentially, or mutations against which these drugs are ineffective, and in green which they're effective. And you can see that there are some that are resistant to all three, but not to the fourth one. Some that are sensitive, for example, crizotinib, there's a particular mutation that's sensitive to crizotinib, but not to ceritinib, et cetera. So again, this will continue to evolve as we get more data in the clinic about the mutational importance. Now, all of the agents that are approved in the second-line setting, including brigatinib, are, of course, quite effective. So this is data on brigatinib, which is effective in patients that have progressed post-crizotinib. This is data on ceritinib. And an important point here to make is that it is also effective in patients that don't have a mutational mechanism. And it may just be effective because it's a much more potent drug than crizotinib, regardless of whether or not there's a mutation present there. And similarly for alectinib, which is a very potent ALK inhibitor, in the crizotinib-resistant patient population, it is also similarly effective with a response rate of 50%. It is incredibly effective in the naive patient population here in the original phase 1 trial from the Japanese group with a response rate of 94%. And this is really one of the highest response rates I've ever seen for a targeted therapy in lung cancer. Whereas in the resistant setting, all of these agents have a response rate of somewhere in the 50% ballpark. Lorlatinib here, again, not approved, but being studied, has clinical activity in patients with one prior ALK inhibitor, response rates of 57%. In patients with 2 prior ALK inhibitors, response rates of 42%. You can see the overall response rate here, and you can see it's color-coded based on a number of prior ALK inhibitors. And sartinib here, again, you can see second-line ALK TKI post-crizotinib or third or fourth-line therapy. And you can see that you see responses across the board for ensartinib. Now, again, we're entering the era of comparing ALK inhibitors to one another. We heard previously the data from the J-ALEX trial, so the Japanese randomized phase 3 trial of crizotinib versus alectinib, which was a highly positive trial. In Japan, the approved dose of alectinib is half the dose in the U.S., so it's a lower dose. In this trial, patients could have had prior chemotherapy. The ALEX trial, which is the U.S. and rest of the world version of this trial, using the higher approved dose, a somewhat larger trial, and also in chemotherapy-naive patients, again, compared to crizotinib. And from the J-ALEX trial, you saw a remarkable difference here with the curves spreading apart significantly here with a hazard ratio of 0.34, favoring alectinib.
Important results from the Phase 3 ALEX study were presented at ASCO 2017, showed that alectinib was associated with a median progression-free survival of 25.7 months, compared with 10.4 months with crizotinib, and also reduced the risk of death by 53%. Additionally, alectinib demonstrated superiority in its ability to penetrate the central nervous system and control tumor growth in the brain. At 12 months, the incidence of brain metastases was 9.4% with alectinib, compared with 41.4% with crizotinib.
And again, a question is this going to fundamentally change our standard of care now if we now have the positive J-ALEX trial and the ALEX trial, what are people going to do in terms of their first-line ALK inhibitor therapy? ALK patients are a population of patients that are much more likely to get brain metastases. Crizotinib does not effectively get into the brain, but our next-generation drugs, alectinib and brigatinib specifically, both are good agents in penetrating the CNS and controlling CNS metastases, and again, an option for patients other than radiotherapy for treating CNS metastases. So how to think about TKI progression? I think first decide when to switch to therapy. Is that at the time of radiographic progression or symptomatic progression? There's data on use of post-progression therapy of EGFR inhibitors and ALK inhibitors as well. And I think it's an individual decision when to do that. I think we should, at least on the EGFR front, this should be guided by biology where it's the most clear that if you have a T790M mutation, you have a specific drug approved for that. I think it's a little bit less clear in the ALK space. Again, it may evolve over time with the mutational mechanisms perhaps becoming more common with the more prevalent use of alectinib. And at least in my own opinion, you use your best drug first when feasible, when you have choices of different targeted therapies.
All right. So Dr. Yanni showed you earlier what the pie chart looked like for drivers in non-small cell lung cancer in the late 90s, when all we really knew about was KRAS, which occurred in about 1 out of 4 cases. But since then, following the discovery of EGFR mutations in 2004, as you can see here on the left, the pie chart has considerably filled out. In this specific pie chart, you're seeing the results of comprehensive sequencing at our center, where the unknown slice of the pie is down to about 12% now. Now, I will say that these slices constitute both clinically actionable alterations, for which there are paired therapies that you can see on the right, either FDA Approved therapies for EGFR and ALK that Dr. Yanni discussed, or therapies for ROS1 and the other genes that we're going to discuss today. So as we know for EGFR and ALK, these drivers beyond these first 2 driver-positive subsets are also largely mutually exclusive. Speaking of ROS1 and RET rearrangements and other drivers such as MET exon 14, here you see in this plot of the same data set from the previous slide that many of these events do not significantly overlap with each other, really underscoring their likelihood of being strong drivers of cancer growth. Now, what we're going to do in this session is, since these alterations are much less frequently found in EGFR or ALK, we're going to drill down a little bit and reintroduce the biology of these tumors and talk also about clinical features. And we're going to start with ROS1 rearranged lung cancers. As you can see here, these were found in the late 80s, first in glioblastomas and in 2007 in non-small cell lung cancers. What I'd like to point out is that structurally on the right, you'll see that these fusions share many features with ALK rearranged lung cancers. First of all, there are a variety of upstream partners. CD74 ROS1 is the most common of them. And if you look here in these red bars, you'll see that the downstream ROS1 gene does, like ALK, maintain the ROS1 tyrosine kinase domain that drives growth. And similarly, there are many clinical features that are shared by ROS1 rearrangements and ALK rearrangements. In this slide, you'll notice on the upper left that the frequency of ROS1 rearrangements is about half of ALK rearrangements. However, all the other clinical features listed here, young, never a former light smokers who get these tumors, largely found in adenocarcinomas, these are features that you're familiar with ALK rearranged lung cancers. There are many means of diagnosing ROS1 rearrangements. We used to employ methods like FISH, for example, but many have migrated towards comprehensive platforms like next-generation sequencing. There is a correlation between IHC staining that's positive and the presence of a ROS1 fusion, as we've seen for ALK rearranged lung cancers. And of course, many liquid biopsies are able to interrogate and detect ROS1 rearrangements. Now, crizotinib is a drug that is a multi-kinase inhibitor, and beyond ALK has activity against both ROS1 and MET. And here you're seeing the results of the Profile 1001 study, the same phase 1 study that in an expansion cohort first launched the eventual approval of the drug for ALK rearranged lung cancers. As you can see here, the waterfall plot for ROS1 rearranged lung cancers looks very similar to other driver-positive subsets, with many deep and complete responses, as you're seeing over to the right, and an overall response rate of about 72%. But perhaps what's more striking for targeted therapy in ROS1 rearranged lung cancers is really the durability of response. And so on the left, you're seeing the swimmer's plot of these same patients with a median duration of response of almost 18 months. You're seeing a Kaplan-Meier curve of the median progression-free survival, which is approximately 19 months, and almost double what we expect to see with the exact same drug when we treat patients with ALK-rearranged lung cancers. So suffice to say, as you all know, Crizotinib has been approved by the FDA for the treatment of patients with advanced ROS1 rearranged tumors, as seen in the bottom half of this slide. There are other drugs with ROS1 activity. This is a series that was presented at ESMO of Osimertinib, a drug that, as you've heard previously, also has activity against ALK. You're seeing outcomes here that are not very different from the response rates we saw in the earlier slide. So response rate of about 62 to 67%, depending on how you cut the data. Durable responses here approaching 19 months, and also the waterfall plot showing the majority of patients have disease shrinkage with therapy, and also there are many deep and complete responses as seen here. Now, there are other drugs with activity against ROS1. As I mentioned, Cabozantinib is one of them. What I did want to highlight on the upper left here is that not all ALK inhibitors are ROS1 inhibitors. So Crizotinib and Osimertinib do target both ALK and ROS1, but other drugs like Alectinib, for example, do not have activity against the ROS1 kinase. And Cabozantinib has no ALK activity, but can be very powerful against ROS1. And you see the effects of Cabozantinib in a patient that we treated at our institution. This lady was treated with Crizotinib for a ROS1 rearranged tumor, and on progression, we found an acquired resistance mutation that is closely related to a mutation that has been found in ALK-rearranged lung cancers. We knew that Cabozantinib had activity against this specific mutation, and we treated this lady with Cabozantinib, and you see here that we reestablished disease control with the second TKI. So this highlights the fact that with ROS1, potentially the paradigm of sequential therapy coming in with one pill and following up with another is something that we might see as these drugs develop. Of course, there are other therapies like Lorlatinib that was previously discussed that also have ROS1 activity that are currently being investigated. Moving on to rearranged lung cancers, this has been a focus of my research. Similar to ALK and ROS1, you see that there are many upstream partners, the most common of which in lung cancer is KIF5B-RET. These fusions also retain the tyrosine kinase domain, and they're activating both when they're introduced into cells and can form tumors in mice. Going on to the clinical features, the frequency of RET-rearranged lung cancers is about what we see for ROS1 rearranged lung cancers. It's about 1 to 2% in unselected cases. These are mutually exclusive with other major lung cancer drivers and are also, like ALK and ROS1, commonly found in younger patients who are never or former light smokers, predominantly with lung adenocarcinomas. Interestingly, if you look here, there are some features pathologically that are also shared with ALK-rearranged tumors, such as the presence of signet ring cells. Now, this series from our institution highlighted how these tumors can be responsive to pemetrexed-based chemotherapy. And you'll see here that in comparison to KRAS, patients with RET-rearranged lung cancers do have improved responses, progression-free survival, and overall survival in this retrospective series that seem to track with the clinical benefit that we see for ALK and ROS1 rearranged tumors, some of which was previously reported in series of ALK rearranged patients who are treated with pemetrexed-based therapies. Moving on to targeted therapy, there are a number of drugs that are multi-kinase inhibitors with activity against RET that are listed here. And with the treatment of patients with RET-rearranged lung cancers, responses to therapy can be achieved. In this case, you see here a patient, a young never smoker, who I treated in my institution, who was on a phase 2 study of Cabozantinib. and within just 4 weeks had very substantial clearing of her pleural disease and a metabolic response to therapy. And you see the results of that phase 2 trial in aggregate here in this waterfall plot. We learned a few things from this trial. First, that cabozantinib and later you'll see other multi-kinase inhibitors against RET do have activity against RET-rearranged lung cancers. In this series, the overall response rate was approximately 30%. However, as you'll note, and if you look at prospective phase 2 series of other drugs such as lenvatinib, vandetanib, both in a Korean and Japanese trial that you see here, the response rates are really much lower than we expect to see for EGFR, ALK, and ROS-directed targeted therapy. And there are probably a number of different reasons for the blunted response to targeted therapy that we're seeing in RET-rearranged lung cancers. First of all, as I pointed out, these are multi-kinase inhibitors, are really dirty drugs. And so they have many off-target effects that probably prevent us from really effectively targeting RET. As an example, cabozantinib is much more powerful as an anti-angiogenic agent than it is as an inhibitor of RET. But because of these side effects, you see also that these drugs are not very tolerable when dosed chronically. So looking here at the same phase 2 studies of cabozantinib, vandetanib, and lenvatinib, you'll see substantial dose reduction rates that are mediated by these off-target effects like the inhibition of VEGFR2 and other kinases that result in diarrhea, rash, and hypertension, among other drug-related side effects. And so I think the field of target therapy for RET is evolving very rapidly. Most recently in the clinic, we've seen the introduction of RET-specific tyrosine kinase inhibitors that were designed not to inhibit these other kinases as these multi-kinase inhibitors that I've pointed out do. And so stay tuned for the results of these new therapies. Now, moving on to BRAF V600E mutant lung cancers. Here you'll see that they're present in the LCMC series in about 2% of cases. And while we formerly thought that perhaps these BRAF mutations clustered in former or current smokers, a recent look at our data at Memorial showed that V600E mutant lung cancers were actually found or clustered in patients who were light or never smokers. These are mutually exclusive with other oncogenic drivers, and as you see in this pie chart here, there are non-V600E BRAF mutations that are not amenable to the standard therapies that we'll see in the next few slides, but the majority of cases, about 70% of cases that have a BRAF alteration, have the hotspot V600E mutation. So looking here at how these patients do with V600E compared to those with non-V600E mutations, you'll see that in that same series from our center that there's an improvement in progression-free survival and perhaps an intermediate overall survival compared to EGFR in red and KRAS in green. Granted that if you look at this plot, there are targeted therapies for V600E, whereas non-V600E alterations don't in general respond as well to these BRAF inhibitors, likely mediating the difference that you're seeing here on the left. Now, talking about these targeted therapy agents, first we'll start off with single agent therapy for BRAF V600E mutant lung cancers. And in this basket trial from our center, you'll see that the response rate to vemurafenib when given as a single agent is 42%. That's echoed by this phase 2 study where you see that the objective response rate with dabrafenib is 33%. Now, very interestingly, looking at the biology of these tumors, we're seeing what we've seen in the melanoma world, where for BRAF V600E mutant tumors, there is a dependence on the activity of the downstream MEK protein. And so, like we've seen in melanomas, when you actually employ combination therapy, and here we're seeing a phase 2 trial of dabrafenib and the MEK inhibitor trametinib, you see that the efficacy of targeted therapy is augmented substantially. You have an overall response rate that's almost double compared to single agent therapy. As you know, the combination of dabrafenib and trametinib has received breakthrough designation by the FDA. Now, moving on to the last few drivers, we're going to talk about MET alterations in lung cancers. MET was discovered a very long time ago, and several therapies for targeted therapies for MET have been in development. But perhaps the first series that was presented by Dr. Kamij to expose the vulnerability of a particular driver-positive subset for MET was that same Profile 1001 study, where an expansion cohort of this trial that administered Crizotinib for patients with advanced MET-amplified lung cancers showed that in tumors where MET was either amplified in an intermediate fashion or where there was high amplification based on a FISH ratio, which is MET over CEP7, that was 2.2 or greater, you did see, barring the small numbers in these series, patients respond to therapy. Now, beyond MET amplification, a second biomarker for targeted therapy in MET are MET exon 14 alterations. The biology here is a little bit more complicated, but to try to summarize, these are mutations that effectively knock out MET exon 14. And when you fail to include MET exon 14 in the mature MET receptor, you decrease the binding of a protein called Sybil to the receptor that normally tags the protein for degradation. And so in the absence of tagging of the MET receptor for degradation, you see much more of the receptor on the cell surface that thus drives cancer growth. Now, the clinical features of these tumors are interesting in the sense that these patients look a little bit more like our standard lung cancer patients. They tend to be older. There's a lower proportion of never smokers. We saw earlier that there's activity of targeted therapies in MET-amplified tumors. These overlap with MET exon 14 alterations in about 20% of cases. However, we do know based on individual patients who are tested for both that these are probably independent biomarkers. So specifically, we've seen MET-amplified and non-exon 14 alterations and vice versa independently respond to targeted therapy. The last thing I'll say before leaving the slide is that these exon 14 alterations are much more common than RET or ROS, and the frequency here of 4% approaches the frequency of ALK rearrangements in non-small cell lung cancers. And pretty much the only way you can detect these right now is by employing next-generation sequencing or RNA-based testing, given the substantial amount of heterogeneity of MET exon 14 alterations. These are druggable, and this is data that we presented at ASCO last year, the same Profile 1001 study, an expansion cohort of patients that treated MET exon 14 altered non-small cell lung cancers. Here you're seeing an overall response rate of 44% and durable disease control with the longest patient on therapy approaching 1 year. Now, as you saw in the earlier slide, interestingly, these exon 14 alterations are also enriched in a subset of non-small cell lung cancers called sarcomatoid tumors. And this is one such patient that was treated with Crizotinib and had a durable partial response to therapy. Now, this is good to note, especially given the fact that historically, these sarcomatoid carcinomas were thought to be relatively refractory to cytotoxic standard chemotherapies. And now we have a targeted therapy that may serve a proportion of these patients. So in the last few slides, we'll touch on some upcoming or emerging alterations in lung cancers. HER2 mutations are found in a proportion of tumors, and these biologically echo EGFR exon 20 insertions. You'll see that when you use single-agent therapy like Dacomitinib or Afatinib, that the response rate is in the order of 12 to 15%. And based on retrospective series that employed combination therapy with these TKIs and with taxanes, you do see the overall response rate increase somewhat. But one phase 2 trial is a trial of TDM1 or Adotrastuzumab, where the response rate does seem to be higher at 33% when we molecularly enrich for this population of patients. End to end, there are rare fusions in lung cancers that involve rearrangements of the NTRK gene. There are 2 drugs that are currently breakthrough designated by the FDA for the treatment of these tumors. Here you'll see Entrectinib on the left and Larotrectinib on the right. There are rare cases of lung cancers that harbor these alterations, and as you see in the bottom here, these patients can have very dramatic and brisk responses to treatment. So in summary, there are many emerging, upcoming drivers that are highly clinically actionable, and this makes the pitch to consider comprehensive testing for your patients, especially if they have clinical features such as a history of minimal tobacco exposure. Thank you very much.
This is the discussion section. We're also going to be able to just get the whole panel involved in any questions you may have about non-small cell lung cancer. As I mentioned, we have covered many of these things in the infographics. But let's start off with one of the elephants in the room. Immuno-oncology in driver oncogene-addicted non-small cell lung cancer. Some of the questions that have been asked are, is there any role? Can you combine these therapies? And what is the role of PD-L1 testing here? Who wants to take that first?
Yeah, so we know that based on both prospective and retrospective data, that the response to immune therapy when you give a single agent checkpoint inhibitor seems to be lower compared to the historic 20% that we see for unselected cases. Actually, an interesting series that came out of Alice Shaw and Justin's Gaynor group looked at EGFR mutant ALK-rearranged lung cancers that were treated with pembrolizumab, and the response rate there was 3%. And so in my practice, and as you know, as mentioned earlier, these tumors were excluded from the registrational trials of these agents. I tend to avoid giving these therapies.
And what about the role of PD-L1 testing?
So I would agree with Alex. We don't usually see very high PD-L1 expression in EGFR mutant tumors or ALK-rearranged tumors either. So that sort of correlates, at least to some degree, with the lack of activity. I think the other question that you raised earlier was the combination idea. Yep. And there have been some attempts, and some very unsuccessful ones. For example, with Osimertinib and Durvalumab, there were efforts to put these two together in EGFR mutant patients. And each one of these agents has about a 3% incidence of pneumonitis or ILD. When the agents were put together, that incidence was 38%. And so there are, and for reasons that are not completely understood, there are still ongoing trials of Erlotinib and other EGFR inhibitors, as well as ALK inhibitors combined with immunotherapy. And they, at least as far as I know, haven't met that kind of toxicity endpoints. Whether they'll have any efficacy improvement compared to a single agent TKI remains to be determined.
I don't know if any of you have seen, there's an abstract of Osimertinib combined with Nivolumab, I think, here, which is in the oral session in the developmental therapeutics. In TKI-naive patients, it has an 80% response rate. In TKI pre-treated patients, a 60% response rate. Phase 1 study, small numbers. What do you take home from that?
Probably need more data to make a good judgment.
Okay.
Yeah.
You get those results from Osimertinib alone?
Potentially, yeah.
Okay. Mark and Dave, your thoughts about oncogene addicted? Because people are going to be doing the PD-L1 testing. Now, maybe it's low, but there are going to be some patients where it's high, and they have an oncogene.
Yeah.
Yeah, I just saw a patient in my practice referred up from southern Florida. The first call I got was that the patient's PD-L1, stage 4 adenocarcinoma, never smoker, PD-L1 expression was 80%. I said, well, that's great. Well, you know, what's the rest of the mutation? The patient was totally asymptomatic. Came back a week later with the second phone call, an EGFR deletion 19. And the oncologist referred him in after asking, you know, would you use a TKI or would you use pembrolizumab? I said, well, a TKI in this subset has a response rate of 75–80%. And I know the immunotherapy, despite being 80% PD-L1 positive, is nowhere close to 75–80%. So there's really no issue in my mind that the immunotherapeutic agents do not come in the treatment paradigm before you run through the TKIs. And I say standard chemotherapy, because chemotherapy works in these patients. Immunotherapy has not distinguished itself from docetaxel in the second-line trials. If you know, obviously both Keynote-024 and Checkmate 026 excluded patients with EGFR mutations or ALK translocations. But if you look at the never smoking population in Checkmate 026, happen to know that data, that in the never smokers, the forest plot was way in favor of chemo versus single agent nivolumab in never smokers.
And in 026, EGFR and out were
Excluded.
proactively excluded?
Excluded,
Okay.
yeah,
Okay.
yeah.
Okay. Dave, any thoughts? Any additional
Yeah,
comments?
well, I'm a little bit more optimistic. There's some recent data at the Geneva meeting that suggested the response rate might actually be closer to 15% in about 97 patients were their data post-TKI therapy. I agree with Mark. I had that patient recently of 100% PD-L1 expression in I think it was an L858R mutation, and chose the erlotinib route. But, it's interesting, our colleagues who treat melanoma, and many of you may do that, it's the opposite with BRAF, right? So V600E mutations were like the greatest discovery ever, and then the arrival of vemurafenib and then a MEK combination, and yet that's all abandoned for immunotherapy, and the responses are a little bit higher than they are in lung cancer, but it's not like they're higher than they are with those MEK-RAF combinations. So it's interesting that it's okay in melanoma to give immunotherapy and save your RAF-MEKs, but we don't think that way here. But I know the data out of the Harvard group suggests that there may not be benefits there, but then we have some clinical data that shows responses that equate to what we saw in the phase 1 studies with nivolumab. I just don't think we know. So I reserve immunotherapy for later lines, not necessarily after chemo, Mark, but certainly after erlotinib.
Okay, so this is the latest NCCN guidelines that essentially says if you're T790M negative, so you've been on erlotinib, it says PD-L1 testing, and if you're highly strongly positive, you should be going for pembrolizumab. Do you agree with that?
No, I don't agree with that. That is not evidence-based. These patients were excluded from Keynote 024 in Checkmate 026. So we don't have really any evidence, in my opinion, to support this. I think the standard of care would be chemotherapy in this, right?
Yeah.
And then I think, Passy, it says the same thing in ALK, too.
Yeah, based on...
But, these people were excluded from those first-line studies, so
Correct. Yeah.
It's interesting. Is there anything that you can add in to immunotherapy or chemotherapy that will make it more effective in oncogene? So we have specific examples. Could you add in, and maybe you could address these, could you add in a PARP inhibitor? Does that make chemotherapy and immunotherapy more effective?
Well, chemotherapy or immunotherapy?
Take your pick.
There may be a story there for tumors that have DNA repair deficiencies that strategies with PARP inhibitors might make tumors more immunogenic, but we don't know that. But I think there are interesting studies that have just kicked off, and for example, there was a phase 1 study published in JCO 3 weeks ago of durvalumab and olaparib. So it'd be interesting to see what that shows value in, but there's a whole number of DNA repair approaches combined with immunotherapy that could be a next story for us.
So the other agents people have suggested are HDAC inhibitors or demethylating agents.
The Hopkins group and I think MD Anderson's reported some activity, almost anecdotal, with HDAC, and that's a strategy of this fraction study. One of the arms combines an HDAC inhibitor with nivolumab, but we're waiting kind of larger data sets.
Too early.
Okay. Just in terms of time to response with immunotherapy.
It's the same. Oh, you mean in general? Or
Yeah. If I put you on immunotherapy and you're going to respond, do you respond quickly? Are you like a TKI? Or how long does it take?
You're like chemotherapy.
Yeah.
In the trials, when you look at the time to response,
Most responses were in the first reassessment.
correct, and it was
6 weeks,
it was
8
the same with in the second line trials. It was the same.
Yeah,
as
I think
the
I think it's fair. That's when you take pictures, so you look. But
Right.
I don't know if you guys have had this. I've had patients have clinical benefit, even papillary masses go away in 3 days. So I know it can happen with immunotherapy, but you're right.
Yeah.
All the studies suggest it happens when you do your pictures.
But how often do you have ones the other way around that don't respond till
I would say
18 weeks or
I would say
24?
that's more often. Actually, the studies don't support that. The randomized trials suggest most of your responses are at the first assessment, but you're right. It's more likely you're going to have patients beyond 6 to 8 weeks who have a response than you will in the first week.
Okay. We've got some specific questions often on some of the targeted therapies here. Does combination BRAF and MEK inhibition work for non-V600E BRAF mutations? And if not, what does?
No, so it seems like those tumors are much more dependent on a different mechanism of activating RAF. So that relies primarily on BRAF dimers with other RAF monomers like CRAF. But there are newer agents that are currently just in clinical testing, like the pan-RAF inhibitors, that may have an effect.
Okay. Have we seen any
I
data
have
on those?
seen a response at our center with one of these drugs.
But it seems like, Alex, we get back like reports that'll say a non-V600E mutation, but, you know, available data on, you know, in Cosmic will suggest this could be a sensitizing mutation. I mean, is it safe to say every non-V600E is not going to be sensitive to a RAF-MEK combo?
I would probably just be very careful before considering treating these people with a combination. It's not impossible that some of them may be responsive, but many that we've looked at have not been sensitive.
What happened to the Dacomitinib story in inactivating BRAF mutations?
Yeah, so there's that, there's a report of a response in, I think a D594G BRAF mutation. I'm not aware that it's being explored to a greater extent right now. And all I'm aware of is that these pan-RAF inhibitors are taking more of the stage for these non-V600.
I was telling these guys, I have a patient right now who's been on Osimertinib for a few years, progressed, and we only knew that she had an ALK rearrangement by FISH a few years ago. But I rebiopsied her progression, and there's no ALK present, but there's a sensitizing BRAF mutation. Have you seen the development of BRAF as a mechanism of resistance to ALK?
So not specifically, but we've seen this where another mutation like NRAS, for example, might emerge. Yeah.
But it has been described as a resistance to Osimertinib, I think, hasn't it, Pasi?
BRAF seen as a resistance mechanism to EGFR inhibitors sometimes, even to erlotinib.
Is MET amplification a target, and how do we develop it further in EGFR mutant and as a primary driver?
Okay, so based on individual reports, and they're one of these that are published by Ignatius Wu, I think, in the JTO, where there's a patient who was clearly tested for both and was positive just for amplification and responded. So it seems to be on its own potentially a driver for sensitivity, just like MET exon 14. So right now, we are exploring both amplified and exon 14 altered tumors on several MET inhibitors that are currently in clinical testing, and they are also being explored in combination. We have seen responses in patients that acquire MET amplification in the wake of acquired resistance to an EGFR TKI if they have an EGFR sensitizing mutation.
And MET has been reported as a mechanism of resistance to Osimertinib too?
It has been, yep. And there is a combination phase 1 trial of combining Osimertinib with the AstraZeneca MET inhibitor Savolitinib, and that has had activity in patients with EGFR mutations and MET amplifications.
Okay. Is there a drug for EGFR exon 20 mutations, separate from T790M?
You're talking about the exon 20 insertion mutations? Yeah. Right, so nothing obvious yet. These patients do occasionally respond to drugs like Gefitinib and Dacomitinib, but that's sort of the rare exception as opposed to the rule. These are just like regular EGFR mutations biologically, meaning they behave biologically like EGFR mutations. They, cause transformation in preclinical models. They're in the same phenotypic patient population. We just don't have a good drug. There are drugs in clinical development for this, but so far, I think it's a big gap. Same is true for HER2 insertion mutations, apart from perhaps the example that Alex mentioned of the TDM1, but we don't have a small molecule inhibitor.
Which leads me to the next question, was what is the role of Osimertinib in T790M negative patients?
Yeah, not clear that there is a role unless it's used, unless the T790M negative patient has, for example, MET amplification or something that you need to co-target both EGFR and something else. Of course, T790M negative is very much a hodgepodge of lots of different mechanisms of resistance. In the original Osimertinib phase 1 clinical trial, there was some activity in the patients that were negative, and those were all tissue-based negatives, and there was about a 20% response rate. And as I mentioned in that trial, when the plasma was also collected, and if you actually went back, and I don't think we actually ever published this, if you went back and looked at patients who were negative by their local T790M negative by local testing, central testing, and plasma testing, the response rate was 0. So as a single
like
agent,
a true negative, if you can
true
define
negative, right? So and that was, again, we didn't totally appreciate this heterogeneity that you can be tumor negative, plasma positive in response, and vice versa. But if you're true negative, single agent is unlikely to be effective.
Pasi, I noticed you didn't mention urine testing, or I may have missed it. Do you think there's a role for that?
I don't know if it adds anything above and beyond blood testing, and there's just an inherent convenience of blood testing over urine testing.
Okay. Can someone explain the rationale, because this was in your slide, Pasi, maybe you should do this, of using the best drug first? That was your quote. Versus sequential therapy.
Yeah, I mean, I don't, you know, your best drug, so take either Osimertinib or Alectinib, so it's your most potent inhibitor, gets around the most common mechanisms of resistance in both the Osimertinib case and in Alectinib being very potent against all of the Crizotinib resistance mechanisms. I realize that there are, you know, people talk about using sequential approaches versus using, you know, taking your best drug first. I think in reality, not everyone makes it to the sequential approach. And in the EGFR example, only 60% of patients will ever develop T790M, and not all of those will ever get an EGFR inhibitor, a second-line EGFR inhibitor. But if you start with Osimertinib, again, the trials will show us, you can have a PFS that could be closer to 2 years, similar to what we're seeing in the Alectinib situation.
One of the questions is, if you start on Osimertinib, so you haven't got T790M, what's going to emerge at that point when you develop acquired resistance?
So that is a bit on the knowledge gap side where we don't have a lot of data. So what we don't know yet, that if you start with Osimertinib as your initial EGFR inhibitor, how much of resistance will be mediated by an EGFR mutation or something else. Now, there is a unique EGFR mutation that's unique to the class of drugs like Osimertinib, which is the C797S mutation, which we've never previously seen until we have this class of drugs. And if you fail with that mutation in the frontline setting, so you don't have a T790M, you could potentially be salvaged or treated with an existing EGFR inhibitor like Erlotinib or Afatinib. At least preclinical studies suggest that that's possible. We don't know that that's possible in the clinic, and we also don't know how often the failure happens through that mechanism versus something else. The FLORA study collected plasma on all those patients, and so some of that information will come out when the trial comes out as well.
So that brings me to another question, which is, if you do blood-based testing, how good is it? Sure, we've got to evolve for T790M, but is that a way, if you walk through the door, for me to tell if you have a c-Met exon 14, a BRAF mutation, whatever, ALK gene rearrangement? Are we there yet?
I think it really depends on the specific driver. So exon 14 alterations, I've seen them reported out on plasma-based tests, but they're so heterogeneous that I'm skeptical that we're really capturing the full breadth of mutations that can emerge. But several comprehensive blood-based tests are able to report out both fusions and mutations. They're probably really best at reporting out hotspots like V600E compared to some of these other fusion events or exon 14.
So if you're a community practitioner, how do you know how good your assay is?
Yeah, so that's the problem. With these blood-based tests, we really haven't seen a whole lot of the validation studies published in a journal just yet. So most of it is really sort of your experience with the test and whether or not patients truly respond to therapy.
Yeah, and most of them have a sensitivity in the range of 70%. So, you know, even if you're newly diagnosed, only about 70 or 80% of patients, you'll actually find something there.
Okay.
And so, you know, and again, tissue will be probably more important in that situation.
Okay, this is a good one. If the only difference in the results between Alex and J-Alex is the letter J, should Alectinib replace Crizotinib in the first-line setting?
Yes.
Yes.
Yes. Yes.
If it does, what do you give next when they progress on Alectinib?
So there are newer drugs like Brigatinib and Lorlatinib that might target mutations that emerge with alectinib. So there's been a G1202R mutation that's reported in a patient. So those two agents may have activity. But yeah.
But I think it's important to realize that, the three existing drugs were all tested in crizotinib failure. So we really don't know, or we don't have a lot of data on, do these drugs work in alectinib failures and what, so I think there's a gap there.
Definitely, I think more information needed.
Yeah.
I'm guessing it'll be brigatinib, right? Because crizotinib, I'm guessing, will go to the museum, and
Unlikely to be crizotinib.
Ceritinib,
Right.
I haven't used brigatinib. I think you've used quite a bit of it, Ross. I mean, my sense is it's probably easier than ceritinib, but I don't know.
Yeah, definitely easier than ceritinib. All right, so I think, thank you again for attending this educational event.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening to this activity. To view the rest of the CME, CE, CPE activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/UDX40. This activity is supported by independent educational grants from AbbVie, Boehringer Ingelheim Pharmaceuticals Incorporated, Celgene Corporation, Foundation Medicine Incorporated, Genentech, and Merck & Company Incorporated.